Hello and welcome to MedEvidence Articles, where we encourage community research and education with weekly articles. I'm your host, Benton Loeyball, and this week we are talking about a type of liver cancer. 85 to 90% of primary liver cancers are hepatocellular carcinoma. Why aren't we catching it sooner? An ounce of prevention is worth a pound of cure. Benjamin Franklin. This rings especially true in medicine, where early detection can mean the difference between life and death. One of the clearest examples of the benefits of early detection in medicine is hepatocellular carcinoma, or HCC, the most common form of primary liver cancer. Hepatocellular carcinoma originates in hepatocytes, the main functional cells of the liver. It makes up 85 to 90% of cancer cases that originate in the liver itself, though other forms of cancer can spread to the liver, called metastases. HCC is particularly worrying because rates of many cancers are declining, but liver cancer rates have been rising rapidly in some regions, especially among women. Men are still more likely to have HCC than women, but what makes this disease especially dangerous is that most people don't know they have it until it's too advanced for our best therapies to offer a reliable cure. In hepatocellular carcinoma, hepatocyte liver cells mutate to develop traits that enable them to survive at the expense of the liver and the body. They multiply uncontrollably, resist death, avoid immune system detection, build extra blood vessels to sustain their growth, and spread to other parts of the body. These mutations are genetic, occurring when DNA in the liver cells is damaged, and occur with liver damage, especially cirrhosis. As the rogue hepatocytes reproduce, they accumulate and form a mass, called a tumor, that can double in size every 4 to 5 months on average. Cirrhosis is by far the biggest risk factor for developing hepatocellular carcinoma. 80 to 95% of HCC patients have cirrhosis, and 2 to 4% of people with cirrhosis develop HCC each year. Conditions that cause cirrhosis are therefore risks for developing HCC, and include chronic hepatitis B or C infection, alcoholic fatty liver disease, and metabolic dysfunction-associated steatohepatitis, MASH, formerly known as non-alcoholic steatohepatitis. Hepatocellular carcinoma has one of the highest mortality rates among types of cancer. Despite half a century of research, which has dramatically improved the 5-year survival rate from 5% in 1977 to 22% in 2020, the disease is often detected too late. Think of it like having a hole in your boat. It's okay if you can plug it early, but the longer you wait, the more trouble you're in. Early detection of hepatocellular carcinoma increases survivability by roughly 300%. When detected early enough, doctors can perform potentially curative treatments, including surgery to remove a tumor or a liver transplant. These treatments significantly increase the chances of survival, although they are only effective before the disease has spread too far. Researchers have developed techniques for treating later stages of the disease, including targeting the tumors with local radiation, destroying the arteries that supply blood to tumors, and medications that target the tumor's ability to grow, proliferate, and avoid the immune system. These medications deserve a lot of praise for helping increase survival, even though advanced stages of HCC still resist traditional radiation and chemotherapy. The knowledge from early detection remains our most important tool. Early detection of hepatocellular carcinoma requires surveillance. Surveillance is when doctors actively monitor at-risk individuals before symptoms appear. At-risk patients include those with liver cirrhosis, advanced fibrosis, and high-risk diseases like hepatitis B and C. Surveillance unequivocally increases survival rates by detecting tumors while they are still treatable. Current primary surveillance methods include ultrasound and serum alpha fetoprotein, or AFP, blood tests taken every 6 to 12 months. CT scans and MRIs may produce higher false positive rates, but can still be useful. Unfortunately, even with our best current methods of surveillance, screening identifies fewer than half of HCC patients. Dr. Bharat Misra of Encore Borland Groover Clinical Research states, "Despite following the current guidelines of ultrasound and alpha fetoprotein every 6 months, all of us have encountered patients who have developed advanced hepatocellular carcinoma. There is a definite need for better blood-based markers that can detect HCC when it's curable." Clinical research is investigating new detection methods that will hopefully provide better surveillance. We also need more widespread use of screening methods and better awareness for those at risk. If you match the risk factors for advanced liver fibrosis or cirrhosis, consider talking to your doctor today about screening for this dangerous disease or joining a clinical research study to make a difference. The ounce of surveillance taken today may be able to cure the 3-pound liver of tomorrow. Thanks for joining us on this week's episode of MedEvidence Articles. If you'd like to know more, all of our descriptions are linked in the podcast description below. You can also visit our website at medevidence.com. MedEvidence helps answer the question of who can you trust for medical information. The MedEvidence platform provides valuable information about many medical issues and the insights of evidence-based medicine. MedEvidence educates audiences through engaging and entertaining magazines, podcasts, videos, articles, and presentations. We strive to bring together diverse voices of top-level medical professionals, researchers, and experts to provide unique and engaging content that uncovers the truth behind the data. For more great content, including discussions by physicians and subject matter experts, check out the MedEvidence podcast. My name is Benton, and we'll see you next week.